rhinology and skull-base surgery. He will give us a talk about how I do it, inverted papilloma. So you can start your presentation for 30 minutes.
Thank you very much for the introduction. Open mic, okay, thank you. So, inverted papilloma is something. Is it possible to turn off this light? Because it's too bright. So, and this is my hospital, and it's a big, one of the big centers in Turkey. So, inverted papilloma, there are different groups of tumors. Can you go down? It's too much. Turn it to this side if you want, because I cannot, anyway. So inverted papilloma is something very common and important in our practice. And it's most usually encountered in the 5th through the 7th decades, more commonly seen in males, and arise from the lining membranes of the nose and paranasal sinuses. So the question is, in polyps, is it seen frequently? No. The frequency of inverted papilloma in normal bilateral polyps is less than 1%. It's generally unilateral. Bilateral involvement of the sinonasal tract is very rare, less than 1% of the patients related to septal perforation. So it is accepted unilateral tumor. I will come to this point later. So histology is very peculiar. The epithelium inverts into the underlying stroma. For this reason, it's called inverted papilloma. You see, the epithelium goes inside. Instead of going up, it goes down. Here you see also. And this is also inverted epithelium, inverted epithelium. For this reason, it's called inverted papilloma. One very important issue you should keep in mind is inverted papilloma spread is by metaplasia of the adjacent mucosa. That means it starts from the mucosa and it spreads by metaplasia. What is the surgical meaning of this? You should treat this tumor like a malignant tumor. You should remove at least 1 centimeter around the tumor. We will come to this point again. Staging, there are different staging systems, and these are the most common ones. For example, this is mainly used Krause. It's confined to nasal cavity. It's type 1. If it goes to ethmoid sinuses or medial portion of the maxillary sinus, type 2. Type 3 is if it goes to the posterior wall or sphenoid sinus or the frontal sinus. If it goes extra sinus, it shows extra sinus extension, it's called type 4, etc. And the others are similar staging. The camel staging system is a little bit different because he staged the inverted papilloma not according to the size, but according to the origin, and it makes sense. So type 1 tumor originating from the nasal septum or from lateral nasal wall, and type 2 tumor originating from the maxillary sinus. So this is different classification system. Both have some ups and downs. The originating point is very important, yes, very, very important, but also it has some downs. Radiology, I mean, is important. Now, this is a unilateral lobulated mass, non-homogeneous density, and you can see, okay, thank you. You can see irregular bone densities or flecks of calcification. If you see the calcification, then that makes you think inverted papilloma. But almost 50% of cases, the bone, the calcification stays in the tumor. For this reason, it's thought there are some bone densities. It's normally the bone itself. But if you see calcifications, remember inverted papilloma. MR examination is like this cerebriform pattern because the pathology is inverted. It's the cerebriform pattern, and you can see here, and if you follow it, you can go to the originating point. And T2 and T1 weighted MRI is important because if you have T2, as in this case, for example, this is tumor, but this is not tumor. This is the purulent material. So you don't need to go all the way here. You can operate only this part and you can remove this here. So this is very important to know in advance. But the problem with MRI is you cannot differentiate post-operative scarring from mucoperiosteal thickening or from recurrent disease. So you should look during the operation about the pathology. There is a theory. Inverted papilloma is multicentric origin. This is like mixed tumor here. They say mixed tumor is multicentric origin. But as you know, this is like fingers. It spreads. So if you think you remove it, normally you leave behind some tumors. For this reason, you should be very careful. And most recurrences are found near the original lesion. So they are mostly extension of disease via metaplasia of adjacent mucosa, not multicentric origin. But it's good for us because you can say it's multicentric origin to cover your mistake. You make a wrong operation and then you say it's multicentric origin. That's not fair. So pathologic changes, in this malignancy, it's different in different reports. It's between 2% to 7%. It changes. But the take-home message is you should take all the specimen and send it to pathology, because there may be malignant disease in this pathologic specimen, and you should know. And if there is malignancy, you should treat these patients according to this. And inverted papilloma and squamous cell carcinoma, you should not miss the squamous cell carcinoma. If the onset of symptoms are short, then you should suspect malignancy. If there is history of epistaxis, you should suspect malignancy. If the patient is old, you should think about malignancy. And if there is bony erosion, as you see here, this is typical for malignant disease. So if you see this bony erosion, this suggests malignancy. But always have in these patients MRI, because look, this is a tumor and it looks unilateral tumor in the nose. But if you have MRI, you see fungi-like extension. This is esthesioneuroblastoma. You can see this extension into the brain only with MRI. So for this reason, if you suspect malignancy or even benign tumor, you should ask for MRI. So site of origin is the most important part. How do you know the site of origin? First sign is osteitis. If you look at the CT scans, and if you see this osteitic bone here, this suggests you the site of origin, or this is seen in 10% of patients. But generally, these patients present with focal hyperostosis, as you see here. This is the origin of the tumor. You should think about it. And look, there is focal hyperostosis. This is the origin of the inverted papilloma. And focal hyperostosis, and here, and this is the origin. And This is a tumor originating from middle turbinate, and you see the hyperostosis. Hyperostosis. So this is the origin of the tumor. Sometimes there may be a focal hyperostosis and also osteitis together. You should think about the origin. Why is it so important? Because you should remove the site of origin. And this is cerebriform pattern. If you follow these cerebriform patterns, you can go to the site of origin. This helps you a lot. So, in summary, hyperostosis or sclerosis in the area adjacent to inverted papilloma, this is the site of origin. 10% osteitis suggests the site of origin. And in the literature, it's mainly, its origin mainly from ethmoid region, then maxillary sinus. And these are generally the extension of the tumor in this area to the adjacent neighboring sinuses. So the most common site of origin is the lateral nasal wall in the region of the middle meatus and ethmoid cells. Secondarily, they extend to maxillary sinus, sphenoid sinus, and frontal sinus. Let's come to the surgery. There are different types of surgery, but now the state of art is endoscopic surgery. Microscopic surgery, I don't prefer because you cannot see around the angles. With endoscope, you can see around the angles. The advantages of endoscopy is superior magnification, illumination, angled visualization. There is no external scar because you make it endoscopically. You can inspect the tumor bed, and endoscopic medial maxillectomy is also possible. So endoscopy is a very good instrument in our hands. So what are the principles of inverted papilloma surgery? First, you should have complete visualization. You should see all the area. You cannot work through a very small window. You should see the tumor. You should have a complete visualization. You should identify site of attachment. Because when I started, what we learned was to remove all the mucosa of the nose. Then we learned it's not necessary to remove all the mucosa. Only remove the site of origin mucosa and identify attachments. Your dissection should always be in the subperiosteal plane, and you should remove the mucosa with underlying periosteum and with safe margins. Safe margins means at least 1 centimeter around the site of origin. And you should drill the bone underlying the site of origin, the diseased mucosa. If the tumor attached to the bony medial orbital wall, you can remove the bone. Remove the bone. And sometimes you can drill it, but lamina papyracea, you can remove it without damaging the periorbita. And the cavity should be wide enough to inspect endoscopically after the surgery. Why should we drill? This is a pathologic specimen. You see there are bones here. This is bone, and this is the tumor. The tumor, especially in recurrent cases, there are bony spicles in the tumor or tumor in the bony spicles. As you see here, you should remove all this bone to have a safe margin. So, take-home message, you should drill the bone below the attachment, site of attachment. And post-op follow-up should be done with different angled rigid endoscopes, if necessary, flexible nasal endoscopes. You should see all areas of sinuses which you suspect. So, regarding prognostic factors, tumor location is very important. This is one of the main things. Size is not important because even if it's very big one, you don't need to, I mean, if you pull it, if you remove the site of origin, it will not recur at all. So, which one is important? Extension or site of origin? Of course, site of origin. Extension is not so important. Type of surgery, it depends on your skill, but I generally prefer endoscopic, and in my hands, endoscopy is very successful. And of course, length of follow-up, as you follow the patient more, you will have more recurrences. Histology is important. We discuss it. Multicentricity, I don't believe in multicentricity. And if you look at the literature, endoscopic resection gives almost the same results. Now, our results are better with endoscopic resection, with later rhinotomy, or limited resection as in nasal polypectomy. So endoscopic removal is the site, the state of art. So sometimes endoscopic surgery is not possible. If anterior and lateral walls of maxillary and frontal sinus are involved, then endoscopic surgery may be difficult. Posterior wall of the frontal sinus, you can do it, because posterior wall is in front of you. When you open the frontal sinus, you can see and you can remove and you can drill. The key question is whether you can drill it. We have curved drills and we can drill it very easily. So, don't forget, spread is by metaplastic extension to adjacent mucosa, and you should remove, excise the tumor with adequate margins. So, until now, if I summarize it, find site of origin and remove with adjacent enough margins, sufficient margins, and always drill the bone below the tumor. This is the main issue. So if the medial wall of maxillary sinus involved, you can perform medial maxillectomy. This gives you a safe surgery. For example, this tumor is very big tumor. This is my patient, and it's a huge tumor. You see, this is a tumor covering the whole nose and going down to the nasopharynx. The operation took 20-25 minutes. Even if it is a big one, look at this, almost 15 centimeters. Even if it is a big one, it did not recur. I operated this patient 12 years ago. No recurrence. It's a big one, but I found the site of origin and I removed it. So generally, the recurrences occur at the buttress between the maxillary antrostomy and the lamina papyracea. This is the hyperostosis. This is the site of origin, and it recurred from this area. Indeed, at the end, you should have a clean mucosa. If necessary, I can perform draft type 3 operation. Let me share with you this video. This is an inverted papilloma case. And now, previously, I would start the removing from here. But now, I am looking where it is attached. So you can remove nasal polyps to send it to the pathology. And then if you use shaver, you should collect all the specimen in a bag. And you see, this is not the site of origin. You can work with shaver, and you can remove it. And now then you reach, you see, the site of origin here, very clearly, very clearly. This is the site of origin. If you find this, the other is not so important. If it does not recur from here, it will not recur at all. And then you can make the incision 1 centimeter away from the tumor, 1 centimeter away from the tumor, and you work under periosteum, and then you drill the bone at this attachment area. You see, it starts here and it extends into the sphenoid sinus. Okay. And this is another patient. And this is in the maxillary sinus. This is the tumor here. And we elevate. But now we have very good angled endoscopes and drills. So if you remove it, remove the anterior part, you can see all the area anteriorly in the maxillary sinus. So the anterior maxillary sinus wall involvement, the origin site, is not a contraindication. You see, this is the inverted papilloma, so we should remove it from here. So I elevate the mucosa, and then I remove the tumor. But I should remove also the mucosa with periosteum. So you see, this is the anterior wall, and I can see the anterior wall with angle endoscope. I don't need to go externally. Now I removed, and now I should drill all these bone site of origin. You see, we have curved drills, and I can drill all this area. And since I have a big opening, my postoperative follow-up is not difficult. I can see, and if I see the recurrence, I can go back and remove it again. You see, this is a very good operation, very safe operation, not disabling the patient, and gives very good results. And here you see the anterior wall of the maxillary sinus. This is very important. Why? Because we don't need to go to the anterior wall of the sinus externally. And if you go from canine fossa, you cannot see this part. It's better seen from the maxillary sinus side, from maxillary sinus ostium, and with diamond drills, you can drill all this area. Take your time and drill and clean it. That's the most important part of the surgery. At the end of the drill, you have a very clean bed for the tumor and for the mucosa. You see, all here cleaned, also here. So one compartment behind the tumor. And this is a recurrent inverted papilloma. This is another video. You see frontal sinus is completely opacified, but it's not the tumor itself. It's the purulent secretion. You don't need to operate. This is the inverted papilloma. As I said before, I only remove the free edges. You can remove it piece by piecemeal, piece by piece. And then with shaver, you can collect it. We collect it. We want to understand whether there is any malignancy. And then I am trying to identify the site of origin. This is uncinate process. I remove it. And this is the tumor. So I am trying to create a white area to see. And this is, you see, not attached to the lateral wall. I can remove it. What I am trying to do is to see the site of impact, attachment. So I remove it. Because this is the tumor itself, I should remove all this area. There is no tumor on the septum. You see? It also comes from frontal sinus. And this looks like normal polypoid tissue here. And this is frontal sinus. There is no inverted papilloma. It's polypoid mucosa. No tumor inside. And this is where the tumor originated. Generally, I go one compartment back. After I cleaned, instead of drilling the bone, I go one compartment back, and then I drill this area here. So this patient did not have any recurrence either. So this, if you apply the principles, you will have good results. and I drill, of course, the lamina papyracea. Since I removed it very efficiently, I think the drilling lamina papyracea with diamond drill, it's good and enough. You see, I drill all the bony prominences, and I create a clean and smooth surface for the follow-up. So I can see frontal sinus, I can see posterior ethmoid, I can see the maxillary sinus. So this is the last version of inverted papilloma surgery. So thank you very much for your attention. If there are any questions, I will be happy before I proceed to the next talk. Okay, no questions. I continue the second talk. The second talk, yes, please.
Oui, s'il y a des questions dans la salle. No question.
Okay, thank
so
you.
We
I
move
continue.
to the next presentation,
Okay.
and after that we can
Okay.
also
Okay,
return
thank
and come
you.
back for question.
I am trying to stay on time, not to be late. And this is CSF fistula. CSF fistula is very common in our practice. We have many patients, and during our operations, we have CSF fistulas, I mean cerebrospinal fluid leak, and we should repair our chronic CSF fistulas. What is cerebrospinal fluid rhinorrhea? For the residents, I want to define it. A direct communication between CSF, cerebrospinal fluid containing subarachnoid space, and the mucosalized space of the paranasal sinuses. So some residents ask me, if we don't open the dura, something happens? No. Dura is natural barrier. You should cut the dura and even arachnoid to have a CSF fistula. And this is a video, you see? You see the leak, it's like a fountain. So these patients are not so easy, because I will discuss with you in a minute the pathophysiology of CSF. Normally, cerebrospinal fluid produced by choroid plexus, 20 milliliter every hour, 20 milliliter every hour, routinely. And it is absorbed by arachnoid villi. And then it goes from the lateral ventricle to the third ventricle here, and to the fourth ventricle here. These are the lateral ventricles, third ventricle, and fourth ventricle. And CSF circulates from ventricles through foramina luschka and Magendie to subarachnoid space. So this is foramen luschka, and this is Magendie. So from here, it goes to subarachnoid spaces. And total CSF volume is 140 millimeter. 20 millimeters is in the ventricles, 50 millimeter is intracranial subarachnoid space, and 70 millimeters is paraspinal subarachnoid space. So every hour, that means if every hour we secrete 20 milliliter of cerebrospinal fluid, that means to have the balance every hour, the arachnoid villi absorbs 20 milliliter. That balance is very important, and it keeps the CSF pressure between around 40 millimeters in infants and 140 millimeters H2O in adults. So this is a balance as everywhere in the body too. You see, it is secreted by the choroid plexus, and this is choroid plexus as well, and it's absorbed by the arachnoid villi. So There are some conditions with elevated intracranial pressure and associated cerebrospinal fluid rhinorrhea. What are these? Non-traumatic CSF rhinorrhea. This is especially very common in obese ladies, mid-age, around 30 years of age. The ladies come to you with a unilateral watery discharge in the recent month, for example. This is because of the high pressure in the obese ladies. Also, if there is benign intracranial hypertension, they may have spontaneous rhinorrhea. And in the empty cella syndrome, these are more difficult to treat from the other vines. So traumatic is easier. It may be non-surgical, penetrating or non-penetrating, or surgical. It may be acute or delayed. Traumatics is divided into two parts, high pressure leaks and normal pressure leaks. So high pressure leaks, as I told you, benign intracranial pressure or in obese ladies, etc., with high intracranial pressure. But there are also some patients with normal pressure leaks, but that if it is spontaneous, it's seen less. So this is an iatrogenic UC, CSF leak, and no dura, the bone is lost and there is no dura, and this is the arachnoid part, and you see the CSF discharge here. So how to diagnose? If you have a patient like this, first you need high-resolution CT scan. What does it mean, high-resolution CT scan? It must be 1 millimeter. 1 millimeter cuts. And you can use beta-2-transferrin protein, and you can use MR cysternography. I will come to this point again. This is traumatic. You see there is trauma, you see the pneumocephalus in the brain. And this is an encephalocell after the trauma. And you see iatrogenic, the surgeon entered the brain, and there is encephalocell and drainage. This is the preoperative view, and this is the postoperative view during the surgery. So beta-2-transferrin is very common in practice, and this is the CSF. This is the serum, and in CSF you see the beta-2-transferrin line. But in serum, there is no line, and this is the fluid we collected. And you can see no line here, so this is a negative example. But if we look at this patient's nasal drainage, this is normal controlled CSF. Controlled CSF, we have it in from other patients. And this is the serum, no. And this is the sample. You see the beta-2-transferrin line here. That means this is positive. If I cannot see the site of leak, I never operate the patients if beta-2-transferrin is negative, because I don't want to be in jungle. I enter and I cannot find the CSF leak. I need a positive result with beta-2-transferrin. Beta-transferrin is another modality, but you should do it in your own clinic. It's cheaper, easier, and faster, but you need to establish it, so I will not talk about it. The other thing is MR cysternography. This is a very good technique, and it's in the use for the last 25 years. And its sensitivity is 87% and specificity is 57%. The issue here, everybody thinks, the residents, we give intrathecal fluorescein. No. MR cysternography, you don't give any intrathecal drugs. You take this MRI and then you play with the colors and you make the CSF brilliant and you can follow it. You see, this is CSF and the leak is here. So it gives very good results, very good results. So but the problem with MRI, cysternography, if there is no flow, sometimes the flow stops. You cannot see the leak. It should be a leaking CSF. Otherwise, you will not see it. But sometimes we need to give an intrathecal fluorescein to identify, to see the site of leak. And for this reason, we give intrathecal fluorescein. But with the fluorescein, we have some problems. Because if you give higher dose, it causes convulsions, epilepsies. So we give 1 hour before surgery intrathecal fluorescein, and we collect 10% of sodium fluorescein and 1 millimeter from this, and we dilute it with 10 cc of the patient's CSF, or the same way 5 cc sodium fluorescein, and you take 1.5 milliliter and you can dilute it with 5 cc of the patient's CSF. So it depends on you, 10 millimeter or it's the same. And then 2 millimeter of this solution you re-inject into the intrathecal area. And then you put the patient in the reverse Trendelenburg position for 30 minutes. And then this, you can see the leak. And it gives you the color. And sometimes, if you want, you can use blue glasses to see better the leak and pathology. And you see, normally with endoscope, it's seen like this, but you can see here the CSF leak with fluorescein, and it's an encephalocele normally. So it's very helpful. If you need it, it helps you. So what about external approaches? With external approaches, there are some very important disadvantages. What are these? One is the risk of anosmia. The second one is, due to retraction, there is possible cerebral edema and encephalomalacia from frontal lobe retraction, and there may be intracranial hemorrhage. So endonasal approach is much more much more reliable. And this is a lady. Now she's 25 years old. I operated her when she was 9-year-old, 16 years ago. And she was operated by a neurosurgeon. And they opened the brain, and the girl cannot smell anything anymore. And they put cartilage and bone here. But look what happened. It slided down, and it created a continuous chronic CSF leak, you see? Instead of staying horizontal, it stays vertical, and it prevents the closure. It has a negative effect. So never believe that external approach is more reliable. No, endoscopic approach is more reliable. But you should be an experienced surgeon. So let's talk about intranasal approach. It was first closure with endonasal surgery by Oskar Hirsch in 1952. And in 1981, Wigand pioneered endoscopic rhinorea closure with a free mucosal graft. He passed away, of course. He was a good friend of mine. And let me share you a case. This is a very nice case. This patient was operated in another university by a neurosurgeon. This is a hypophyseal surgery, 49-year-old male patient, and there happened CSF fistula after endoscopic pituitary surgery. And 3 trials of closure of CSF fistula with neurosurgeons and ENT friends without success. And then the patient lost his consciousness, and MR showed diffuse brain abscesses. And the head of neurosurgery department invited me whether I can help them or not. And this is, you see, this is the abscess in the brain. You see, all the brain is full of abscesses here. No consciousness. You see, abscess here, everywhere there are abscesses. Abscess here too, So there is no consciousness. And what we did, we first took the patient to the operation, and first neurosurgeons drained the abscesses, because I cannot drain this abscess from the nose, not possible. So the neurosurgeons drained all these abscesses from all these areas with burr holes. And then I entered. This is the video of the surgery. Look, this is the sphenoid sinus, and there are some adhesions. I remove them. You see, this is sphenoid sinus. I should open it to see the CSF leak, the defect. And this is where they put the fascia, and this is the leak. It's draining. It's draining. And instead of closing it, they created a chronic CSF fistula. You see? It's now necrotic. I should remove it altogether. With through cutting forceps, I remove it. Now I see the leak. This is the leak. So I need to see better the inside. So I remove the bone. And now I try to identify the dura. With seeker, I separate the dura from the surrounding bone to put my fascia or the other repairs. So I first put the fascia lata. I took it from, normally I take temporal fascia, but I need bigger. So I put it, and I pack it in between the dura and the bone. So this is inlay surgery. So I cover it completely. And then, because they tried to repair it 3 times, and you see the high pressure, because there is a high leak and there is a high pressure. When you cover it, the pressure will be very high. And I took a septal cartilage, I corrected it, and normally I don't use this, but this is a long-lasting CSF. The pressure, the secretion is very high, and the secretion will continue at least 24 hours. When you close it, that means a lot of CSF fluid. And then I put it, the 3rd layer after the cartilage. Now there is no bulging. So we can discuss whether we should put cartilage or not after my lecture if you want to discuss it. So I pack it, and then the last layer is the onlay layer. This will be a fascia and plus the mucosa or direct mucosa. And then I support it with Surgicels and gel foams, and then I support this with rapid reno or some with other packings. It's very important. So what happened to this patient? The next day, the patient was good and removed from intensive care to the normal care, and in 2 days, we discharged this patient. So the patient was dying. So through correct surgery saves the lives of your patients. Now, this is another example video of a wrong repair, a mistake done by the surgeon. So the CSF leak was here, so he put this cartilage. Let's see it. Oh my God. Play? No? No? Yes, no, no. Okay. It does not play, huh? Okay. Anyway. I cannot play it. So they put the cartilage on top of the bone. I can play it later from the other area. And then I removed the cartilage, and then I made the same dissection between the dura and the bone. You see. And I don't put any cartilage because it's not a big one normally, but in this case I put again. Normally I don't use it anymore. And then temporal fascia, cartilage, and one more layer, and then cover the defect with mucosa or fascia and mucosa. And I put also the Surgicel, because Surgicel, the importance of Surgicel, it creates the granulation, stimulates the granulation. So Surgicel is very important, and I support it with the gel foams. And then I put Rapidino, and I keep this Rapidino for 7 days. That's very important, 7 days. And then I took it out. So let's discuss a little bit about the issues. What about our approach with acute and chronic? If it is acute, no problem, it's easy to treat. But if it is chronic, that means high production of CSF, and it will increase the pressure in the brain. So you should be careful. Location of defect is very important. Size of defect is very important, I will discuss. Should we use bone or cartilages? I never use bone, because bone goes to osteonecrosis and causes granulation. I don't like it. If I have to use, I use cartilage, or now I don't use cartilage anymore. Lumbar drain. Lumbar drain, I don't use lumbar drain. Why? Because if you drain the CSF, that means the CSF will be secreted. As you remove CSF, it will be secreted. And you remove the lumbar puncture drainage on the 5th day. The 5th day is the weakest time of the tissues. So what you do is harming the patient. Let the pressure stays high in the 1st day, because the 2nd day, when you prevent the leak, it will decrease by itself. Onlay or inlay, I prefer always inlay. And graft and flap, I prefer grafts. Only in chronic patients, and if it is a big one, I prefer flaps. I will come to it, what kind of flaps I am using. And as graft materials, temporal fascia is the best. If not, I take it from the leg. So the frontal sinus, if it is in the very lateral recesses of the frontal sinus, it's difficult. But now, even if in the upper 2/3 of the posterior wall of the frontal sinus, I can treat it through the nose. And the other issue I should discuss with you is the location of the defect. You see, this is the anterior ethmoid artery, and this is the cribriform plate, crista galli. So this is important, because if you put inlay, I said I prefer inlay, but you should know when to inlay, when outlay. If your defect is here, if you put it inlay, if you put it here, you should cut all the nerve fibers. So what should be done? You can put here inlay and here outlay to prevent the cut of the olfactory fibers. And you should preserve them. Also, you can, if you have ethmoid artery, you should cut the ethmoid artery. You cannot cut it. We can cut it, but not necessarily. So in these cases, you should be careful. And this is lamina papyracea, and you can put, I mean, there is no nerves here. You can put your fascia here, and you can bring it out here, like this. And in the defects, the size of the defect, if the defect is small, smaller than 0.5 centimeter, if it is acute, you can put a mucosal graft and you can support it, and it will heal by itself. If it is due to, acute and due to surgery, no high pressure of the CSF. And for this bath plug closure is very good. You take some fat, you put the suture like this, and you push it up, and then you pull the string, and it plugs it. And then you put some onlay grafts. So that's for small. If you want to dissect the dura from the other sides, you will damage. Don't damage it. Put it. It's acute. If you close it, it will stop by itself. If it is bigger than 0.5 centimeter, you need soft tissue support and mucopericondyal graft. You can use autografts from fascia lata, fat and muscle, or temporalis muscle and fascia. My experience with homografts with lyophilized material is not good because it does not get in accordance with the tissues around it. So I always prepare auto tissues. And a composite graft, very rarely, even we learned after skull-base surgery, even if the defect is very big, very, very big, you don't need to put it. You can put a fascia, and then you can bring Haddad flap, for example. So it's enough. You don't put. But if it's hanging, then you can use septal cartilage. And inlay is, don't forget, it's not inside the dura. It's between the dura and the bone here. And if it is between the bone and between the mucosa, it's only graft. So this is preferred if inlay technique not feasible due to nerve or vessel injury risk. And this is, as I told you, this is subarachnoid space. To have a CSF fistula, these arachnoid matters should be defected. So it should be, the defect should involve all these layers. So I discussed this for you. If there is big meningocell or encephalocell, you can use cartilage. I like grafts. Why? Because grafts do not contract, but flaps contract. For this reason, I don't like flaps. Or it should be very flexible, like Haddad flap. You should, even if there is some contraction, it should not open. And it's technically more demanding. What kinds of flap? Inferior turbinate flap. It's very good flap. You can use it, but it is for small defects. Otherwise, you cannot use it. But the problem with this CSF fistulas was Pittsburgh experience. In Pittsburgh, they were doing a lot of skull-base surgery in the 1990s. And they lost 25% of their patients because of this CSF fistula and infection and meningitis and cerebral abscesses. So the chief of the department said, no, I will not allow you to perform this surgery because the complication rate is so high, 25%, no more. But then they started to use Haddad flap. And this Haddad flap, they had in the first group 43 operations with only 5% CSF leak. And then Kassam later, his very well-known neurosurgeon, he found 4% and they were allowed to do the surgery. And this is very well vascularized Haddad flap. Superior arc of rotation is excellent. Enough surface area, as much as you want, you can prepare it to cover the entire anterior skull base. And it's endonasal, no external scar. It's sturdy and pliable. You can use it as you wish, very flexible. And this is the only thing you should preserve, this vascular pedicle, because this sphenopalatine branch of nasoseptal artery, which is the sphenopalatine artery branch, it's the workhorse of this flap. If you preserve this artery, your flap will not go to necrosis. And this is sphenoid sinus ostium. This is choana. So you bring your flap from here to here, so you will not have any problems. And you make the cuts, you bring it here, and you elevate, and then you can push it in the nasopharynx or sphenoid sinus, or you can bring it forward, and then you can use it as you wish, and you can cover a long area with this hot dot flap. And this is the post-operative view. You see it closes and it heals in a fantastic way. Nasal packing, I use Surgicel. I told you why I use it. I don't use tissue glue. Why? Because two reasons. It's very expensive. And the second thing, neurosurgeon says, yes, I put tissue glue and I treat it. No, it's your surgery. For this reason, to show them it's not the glue, it's our surgery. I don't use tissue glue. And you can put Merocel or Rapid Rhino or balloon to keep it in place for 1 week. For the posterior follow-up, sorry, I have a few more minutes. Nose training, it's very important. You should give stool softeners, Gaita softeners, and open mouth sneezing. You should give diuretics, diazomite, and you should keep the packing 7 days, and the patient should lie head high in the patients. What is the reasons of failure? Inability to localize the defect, insufficient graft size, graft displacement, flap contracture, incomplete apposition of the graft to the skull base, poor wound healing, and wrong technique. For me, two things are very important in many patients. They couldn't identify the defect. They treated the wrong areas. I have many stories. I don't want to take your time, but they treat the wrong place. For this reason, the first failure is this, and the second one is wrong technique. You should use the proper technique for your surgery. Again, to drain or not to drain depends on the cause and timing. If there is skull base trauma, you can drain and no more surgery. You can try it. If you expect you can stop the CSF, you can try it. Iatrogenic from sinus surgery. If it is acute, not chronic, then you don't need to use drain. But in spontaneous drain, leaks, or in chronic leaks, you can use it. Disadvantages of lumbar puncture is hospitalization, prolonged spinal tap headaches, meningitis, and pneumocephalus. These are the disadvantages of the lumbar drain. And lumbar drain, when you put it, it increases the CSF secretion. If the CSF secretion increases, then you will have problem after you remove it because the pressure will high. And if your tissues are not strong enough, it will cause the CSF leak again. So lumbar drain to decrease the pressure, but you should keep always in mind, you don't need to decrease the pressure in all patients. Thank you for your attention. So I think my time is over. If you don't have any questions, I stop my talk. Any questions?
Yes, if we can take a question, the time from to our colleague to install his computer. So if there any question, I think it was very clear.
Okay.
I have a question for me,
yes.
Inverted papilloma.
Okay.
So if you have some bad signs regarding CT scan and MRI, do you change your management strategy? If you have bad sign on CT scan or MRI, you have erosion, destruction, osseous destruction. So osteolysis, for example, do you change your strategy, management strategy? Do you change it? Yeah.
Radiology is very important for me. In inverted papilloma, I myself look at the radiology before the operation. First, to see whether there is any dissection of bone and where is the hyperostosis, to identify it, and I plan my operation according to the radiology. Absolutely. Thank you very much for the question.
Thank you also. Thank you. So we introduce our colleague Abaidin for the next presentation, profile limit in rhinoplasty. So you can start.
Thank you very much. It's working? Okay. So this is the final talk of the day. Still good to see some people here. I'll be speaking on profile limit in rhinoplasty. My name is Fazıl Apaydin, and I'm from the west coast of Turkey. Turkey is the capital of rhinoplasty. I know in this country, unfortunately, among ENTs, you're not very interested in rhinoplasty, but in the coming 10 years, it's not going to be the case. I can tell you about that. So I'm working a lot in Turkey, in Europe, and in the world to promote facial plastics within ENT, because in Europe, we have subspecialties, and facial plastic is a very important one of them. And I'm a board-certified facial plastic surgeon since 2007. I'm an ENT professor too. So this is our academy in Europe. I hope you can join us one day. And we have programs for fellowships, for observerships. If you are interested, you can come and visit us when you want. I have my own course in Izmir. I do it every August, the end of August. So this is my university hospital, which is called Ege University. Ege is the name of the sea that we are next to. This is our famous clock tower in Izmir. So, profile is the second most important parameter in rhinoplasty. In the era of Instagram, everyone is taking pictures now. And precision profile plasty is becoming more important for surgeons. Many surgeons rely on their aesthetic eye when dealing with the profile, but we must work on creating the desired and best profile before going into surgery. I'm teaching everyone to work on this before surgery. So we must do the surgery before we get into the OR. This is my principle. So I'm going to speak on 4 things. First of all, aesthetics of the nose and the face. The radius of the nose can be deep, normal, or shallow. The nasal starting point can be high, normal, or low. Ideally, it should be at the level of the upper palpebral fold. The profile should be straight in males. In females, it can be a bit scoopy. Tip rotation is an important part of the surgery. It's an imaginary line that is passing from the forehead, tip of the nose, and from pogonion. And you are going to change the tip according to this imaginary line. Tip projection is the distance of the nose from the face. So every day, I'm discussing projection, rotation profile with my patients. And we can make measurements as well. The most often used one is practically the Simon's one. The length of the upper lip is equal to the length of the nose, and there are other formulas too. The collimator show should not be more than 2 to 4 millimeters, and that should be a double break angle as well. When it comes to profile planning, I have 7 steps before surgery. First of all, I'm using a patient-reported outcomes measure, which is called SHNAS. It has 10 questions. Each patient must answer these 10 questions before they come in and see me. The second thing I do is I'm using professional cameras to take pictures in a professional setting. As a facial plastic surgeon, I must validate my pictures if I want to use them in a standard way. These 6 pictures are a must: frontal, laterals, basal, and obliques. In addition to it, I take another 8 views by using a ruler, semi-obliques, semi-basal, and smiling views as well. Then I'm using a Rhinobase, a software that I started in Chicago and finished in Izmir, Turkey. It's been there more than 20 years. It's a wonderful program. In this program, we can make a photometric analysis very easily, and an aesthetic analysis too. When it comes to nose design, I do imaging in Photoshop. I used everything possible. Imaging is the best with Photoshop. So I can show the patient how much I should resect from the hump. I like giving the patient at least 2 options in terms of projection, rotation, and profile. And then I make measurements in Photoshop. I measure at 7 different zones in which zone I should resect how much. Before I go into surgery, I know all these things. And then I take a printout if I need to. I publish this in one of our journals. If you are interested, you can read more about that. And I also create a profile template. It is, for me, the holy grail, because I can use it as a guide during surgery. So what I do with these profile templates, I was using it from plexiglass before. I can show you during surgery. This is during surgery. It's 1-to-1 life size out of plexiglass. I can measure the original one and my desired shape. If I reach my desired shape, I end the surgery. And I can do self-assessment by looking at these profile templates and the post-op result. The same thing you can see in another patient. This is the profile plate before, template before. This is after, and after surgery, I reached my goal. And I decided to print them in my own office. I was sending it to a company before. Now I do it in Photoshop. In Photoshop, I can get 3D images easily, and then I print it out in my own private practice. It takes about half an hour. Then I can make measurements on the patient's face if it is fitting or not. When it comes to profile alignment, we need to look at all thirds, upper, middle, and lower third of the nose. To get rid of the bony hump, I've been using all of these things on a daily routine: rubinosteotome, rasp, scissors, burr, and piezo. So if I'm doing an invasive technique, here I'm cutting the perichondrium. You're going to see better how I do it, because I do not want to resect the perichondrium with the cartilage. And if you dissect this perichondrium, which you can suture back, it's a nice camouflage material. There is a thick perichondrium over the middle third. Then I dissect the periosteum from the bone. This is a small cut at the level of keystone area. I cut the cartilage there. And after cutting the cartilage here, it's incremental reduction of the hump. This was the traditional technique that I learned 30 years ago, actually. Still, it has a place. So by using a rubinosteotome, you can kindly get rid of the bony hump very easily. Of course, you should know how to use the rubinosteotome. It should be sharp enough. Otherwise, we can end up with problems. Okay, so this is one of the techniques. And in the end, you take one small piece out by using a hemostat, as you see here. This was a big bony hump. I like rasp too, but I use it more sparingly nowadays. So this is how I do it. Before I start removing anything from the dorsum, I like to make a cut on the perichondrium first. When I started dissecting this perichondrium, I was amazed how thick it was. And before, I was simply sanding it away. Because in the long term, the skin shrink wraps, and whatever I do as a small irregularity, it shows. This flap is a wonderful flap to prevent this happening. So this flap is vital to me. In external rhinoplasties, if I'm going to get rid of the hump, I do it almost routinely. And when you do that, you see the upper lateral cartilages in front of you directly. Having done this, I switch to the bone. I dissect the bone of periosteum, but I should make a small cut. The idea is to keep the periosteum together with the skin above, so it becomes like one layer. It's a very small, important trick for me. Here, I can work blindly because I can feel the bone and I can dissect by using a Joseph very nicely. Then I dissect under the middle third because I do not want to cut the mucopericardium under the middle third. So I'm now ready to get rid of the hump. This was a big hump, so I removed a small piece of it just to have an insight. I usually do not do this much. You will see how I do it actually. Then we can dissect the upper lateral cartilages away from the septum and remove from the septum as much as I like. Here I put 2 spatter grafts and suturing the upper lateral cartilages directly on it to have a better angle of. So in recent years, I'm using piezo more and more to get rid of the bony hump. It is very nice because I can do everything under direct vision. The good thing is it does not give any harm to the surrounding soft tissues. For me, this is very, very critical, and it takes about a few minutes to do that. And I see what I'm doing very nicely. By using different types of piezo, I can have a very nice, smooth transition from bone to cartilage. I told you I'm measuring on 7 different zones, and before I go into surgery, I know how much I should resect. So I'm making these measurements on the cartilage, and I'm using an 11 blade so I can make a smooth cut, linear cut. When I come to the bony part, there's a small bony part up there. I can use a Rubin if I like, but nowadays, as I told you, I'm not using Rubin too much, I'm using piezo more. So this is the cartilaginous hump I resected. Again, using a small Rubin. So when I'm done with the humpectomy, I use spatter flaps. What is it? I turn the upper lateral cartilages in. I use a long, small, thin needle here. When I turn them in, I get rid of the hump by removing the cartilage. Then I do not resect the upper lateral cartilages. I'm using them for spatter flaps. This is a wonderful technique. I've been using this for more than 12 years. I'm super happy because it widens the valve angle very nicely. I can reshape the dorsum as good as I like. I can keep it wider or narrower depending on the need. There are a lot of small tricks. I do not have time to speak about those, but I can tell you when I'm done with this, the dorsum looks as if I haven't touched the dorsum. For me, for years, I call this preserving the dorsum. And when my fellows ask me, how can we resect the hump precisely? Because we're not very skillful like you with the knife. So I designed this hump removing guide. When I close it, it doesn't close totally. There is 1 millimeter in between, and there is a shield which prevents me to cut the pericardium. So I'll show you how it works into action. I call this Mishari 1 because I designed it for a friend, colleague, a fellow of mine from Kuwait. So you put this instrument inside. Remember, I measured how much I'm going to resect on different zones. So when I put this in, when I close it, I'm using number 15 blade to resect the cartilaginous hump. It gives you a wonderful cut. And the shield prevents it to cut anything different from other places. So I like this instrument very much, and my fellows are using this now. A Turkish company is producing it for me. I have no financial relations with the company. So just to tell you how it works, this is spatter flap. The dorsum is wonderful after 2 years. I can see the transition and the oblique views are really very good, and the profile is very good. He is very happy with the result. Another patient like this, the same thing is done with the spatter flaps, humpectomy, and osteotomies as well. Of course, we did tiplasty too. So these techniques for middle wall and upper pyramid work very nicely in these kind of Turkish patients. I'm sure the same thing is valid for here too, because I've been operating a lot of Arabic patients too. When it comes to tip, there are different parts of the tip. So we should be addressing the tip by using sutures first, and then, if necessary, by using grafts. In this young, beautiful lady, I'm going to show you step by step how I go. This is a bulbous tip, droopy tip, and she wants to have a better tip in this case, so I'm going to show you how we can have it. First of all, in recent years, Pitanga ligament became more popular because of Barish, Chakar Barish put it into our agenda. Pitanga can be a useful asset. Honestly, it's not a very super important thing, but it can be helpful to you. So, in this lady, first of all, I'm dissecting the Pitangi's deep portion between the medial crura to reach the caudal septum. I'm bypassing the membranous septum. So the ligament extension between the medial crura and the membranous septum is dissected first. The same thing is done on the other side. As you see here, the index finger is helping me to feel where the tip of my scissors is. I'm touching the caudal septum. When I touch the caudal septum, I am detaching it from the caudal septum. When you go higher, you raise the dorsum automatically. And here, if I want, I can go subpericondially directly, or I raise it, I cut the pericondium in the midline. Subpericondial dissection became very popular in recent years too. So this is the Pitanga ligament deep portion. Then, almost in all patients with droopy tip, I steal from the lateral crura, from 2 to 5 millimeters. Because droopy tip, medial crura are short, lateral crura are longer. And I like also hemitransdermal suture, which gives a better definition to the dome. So I'm going to show you how it's done. Here, I measured by using a caliper, about 3 millimeters stealing from the lateral crus. I'm using 4 PDS suture here. And the first suture I do is the hemitransdermal suture. This gives a wonderful definition of the upper portions, cephalic portion of the dome, but not the dome itself in many of the cases. That is why, after I put this hemitransdermal suture, I pass a high domal suture. It gives the dome a better shape. The traditional one is in the middle, but this is a bit high domal. I pass from the middle part of the the dome and then go higher. This is a mattress suture. I try to keep the knot in the middle so the patient is not going to palpate it after surgery. And this too give me a very nice tip definition. Of course, sometimes even this is not enough, the domal angle becomes a bit wide, I put an additional one. Then the third suture I use is a dome equalizing suture. When I bring 2 domes together, remember I'm working symmetrically. I always measure. If I measure, I can guarantee that I can work symmetrically. I use a suture of 8 or simple suture to bring the domes together in an equal fashion. So with lateral steal, I started getting the rotation I liked very much. And the medial crura starts coming to the caudal septum. At this stage, I go as the 4th suture to septicomolar suture. I have my own classification for that. Depending on where I pass on the caudal septum and from medial crura, I can play with the rotation. So if I want to rotate too much, I do the tongue and groove technique. If I want to do less, I can go from the soft tissues around the medial crura, or a bit more, I can pass from the cephalic portion of the medial crura. In this case, I am passing from the cephalic end, inner end of the medial crura. I start from below first. The idea is to bring the foot plates together because sometimes they are flaring too much aside. It's not a good thing. And when I do that, I give very nice plumbing, fullness to the subnasal as well. So these are 5 PDS sutures. 4 is a bit thick here. And then I put usually 2 sutures. Starting from below, I'll go all the way up. This is the second suture. And you see how I put the septicomolar suture. When I put these sutures, it becomes like an open book. After the second mattress suture, I put a columnar strut. This is the 5th step for me. This strut should be long enough, thick enough, and between the domes, it should be wide enough. This is the ideal one for me. So if I do that like that, I have a very, very good support for the tip. We've been discussing with my friends in the world, should we put caudal septal extension in all the cases? I say no. Some people claim the other way around, but I'm experienced enough to back my results because I follow my results as long as I can. So again, we are starting from below by using 5-0 PDS. I'm putting mattress sutures. Of course, this is bigger than normal. Why I do that? Then I can trim it off according to the need of the patient. This should go all the way up, support the whole tip, and the tip is going to be very well shaped. This is the first suture, and then comes the second suture a bit higher. You should go there. This acts like a spacer. Sometimes we see irregularities of the medial crura. I can get rid of these irregularities very nicely. Transdermal suture is going to be my last suture. So here I did it. I'm not going to show the video of it. Then the seventh step is if I want, I can take the Pitangui ligament down, pull it down. What it does, it closes the dead space over the split area. But if you push it too much, it can cause suppurative settling. So we suture this one here, so we feel the suppurative area, and also we close the dead space. So putting a suture here is a good thing, is a smart thing. So this is her a year after surgery. I saw her a few weeks ago, so she came for the second year follow-up. She's very happy. It is a good result. Again, I'm telling you, there is nothing like perfect in rhinoplasty, but the patient is happy. I am happy that that is the ideal scenario. Another patient, bulbous tip. She's Turkish, but she works in the Netherlands. And you see how bulbous the tip is. You see also the hump. And when she's smiling, it is dropping a bit more. So we made the measurements again. We use our templates. I harvested cartilage first. This is the Pitangui ligament. This is the shape of the lower lateral cartilages. I made my measurements. I'm going to steal about 4 millimeters in this case. I make cephalic trimming here, put a suture, which we call cranial tip suture. Then the tips are defined. Then I open the middle wall. I am now trying to, I use burr here to get rid of the bony hump. Then open the middle wall. This is the cartilage hump resected. Then spider flaps are used, as you can see here. I call this photolog. I try to take pictures during surgery as much as I can. I try to video almost all my cases. So when we're done with spider flaps, I carve a big strut, and this big strut is sutured between the medial crura, and the extra cartilage is cut. And I'm putting 2 aluminum grafts here. I don't use it routinely. And this is, again, Pitangui is sutured in place. Here I made a mistake. I put too much. I'm going to show you what I mean with that. Then we close the case. This is the end of surgery. I was happy in the end. And I reached my goal in terms of templates too. So, same patient, again, using a burr for a few minutes for ENT surgeons is a very simple thing. I used to be a very otologic surgeon, and I was using the drill for 3 to 4 hours. So here, you use it only 1 or 2 minutes. What I'm saying is, you do not always have to obsess by buying a piezo. If you have this burr with you, you can use these burrs very easily and very nicely. This is the Pitangui I was telling you about, dissecting the Pitangui as we have seen before, and it's sutured in place. So this is a year after surgery. She is super happy with the result. I'm happy too, but suppurative area for me is a bit depressed. It looks fine in the pictures. She is happy, but I wish I shouldn't have pulled it too much. So you must be very critical with yourself when you're following your patients. What about dorsum preservation? This is the new trend within the last 5 to 6 years, and it is revitalized. It's a technique which is more than 100 years, actually. There are 2 types of it, foundation techniques and surface techniques. I've been using both in patients. We can use high strip and low strip. What is the idea? The idea is to keep dorsum as it is and to push it down by using one of these techniques. In the middle is the septum, so you must resect from the septum, either from the higher part, from the lower part, or from the intermediate part. If you remove a strip from the lower part, it's called cuttle. If you take it from the high strip one, we tell it Saban's technique, even though it's not Yves Saban who first presented it, but he is the one who revitalized it. And my good friend Carlos from Portuguese, he came up with a Tetris concept, which I like very much too. So I'm going to show you one case here, which I use modified subdorsal cuddle technique. This is a lady with a slight crookedness, hump, and bulbous tip, as you can see here. And we applied modified subdorsal cuddle technique in this lady. So what did we do? First of all, we started endonasally. It is easier to start endonasally in these cases because you can have a better access sometimes from below to caudal septum and to the septum as well. So I like using sharp scissors very much. Then I dissect over the dorsum or the bony part. I do not always have to do this, by the way, but in this case, we have done it. I am going subpericondrially as well. So after dissecting over the dorsum, I'm going to rasp a bit because in some cases, when you push down, it can come up, it can bounce back. To break this, we use different methods. One of them is slight rasping of the bony pyramid here. Then I mark the W point. This is the point about 5 to 6 millimeters behind the anterior septal angle where the upper lateral cartilage is starting. From here, I will make a Z-shaped cut. I'm not going to remove anything. After this cut, I'm going to push it down. It's going to go and overlap because I want to bring it to the midline. So overlapping is a good idea. This is how I do it. This anterior septal angle, make a Z cut, and I remove a piece of bone and cartilage just under the bony dorsum, and I push it down. This is how it works. Of course, you have to mobilize the bony pyramid. To do that, I'm making a wide opening inside the nose on both sides. I dissect the periosteum on it by using a Rubin osteotome, Joseph decollator. Here I like using piezo very much. I love to remove the Webster triangle because if I'm going to push it down, this part can narrow the entrance of the nose. I do not want to have it. That's why I reject the Webster triangle. Then I do transverse osteotomies by using 2-millimeter osteotome. And when we are done with the osteotomies, we have one final cut, which is the root osteotomy, which is going to combine the defect we created. So it's going to, the whole thing is going to come down. Then we suture in overlapping fashion the whole thing. When we did this suturing, it's not going to come out. Then I opened the case. I kept the Pitangui intact. I didn't touch the Pitangui at all because I didn't want to over-rotation. Pitangui is going to help me to prevent this over-rotation. I am suturing the medial crura soft part, for me it's type 1, to the caudal septum, and then I put an additional one, so I reach from here to here. This is a year after surgery. The patient is super happy because I was able to bring it to the midline. I've got nice brow aesthetic lines and brow, it's a very natural tip, as you can see. And the patient is super happy, and the rotation is not too much. Some of my friends in Istanbul are making very small noses, very upturned noses. I do not like that very much. This is another case with preservation, and this time she had a high septal deviation and boxy tip and a hump and a hanging columella. And this one we did the cuttle technique. In the cuttle technique, we didn't go high. We removed a strip of the septum where it is attached to the maxillary crest. I removed a piece of cartilage. This is the small piece that I resected. I'm taking wedges of bone to bring it down. This is called let down technique. The previous one was a mixture of let down and push down, but this one is let down because I remove a wedge of bone on both sides so the bone can come down. Here I'm using rongeur. I do not use rongeurs that much anymore because I want more precision. That's why I'm using piezo more and more. Then I do some osteotomies for the upper parts to join with the transverse osteotomies. The same thing is done on the left side. I dissect over the bone from the outer portion and from the inner portion as well. Then I resect a piece of bone. This is a technique I learned from Fausto Lopez from Mexico. And then we do the osteotomies, percutaneous osteotomies. I am trying to now not to detach the skin at the radix because it helps me a lot to keep the fractured bone pyramid in place. So I am suturing the septum to the antenasal spine. This is a very crucial suture. This is the most important suture in cuttle technique. If this suture gets loose, you're in trouble. It's revision. It happened to me once, and it can happen to you too. And the other thing is, of course, when you want to learn precision techniques, you need to risk that you're going to have a learning curve and you're going to have some revisions. So my revision rate went up to 12% when I started this. It was 6% before. So we are doing the tip surgery. I'm not going to go in details. So this is her 4 months after surgery. So she is fine. The dorsum is the original dorsum. There's the tip and three-quarter view and lateral view, as you can see. And I will show you a few more cases, then I will be done. This is a crooked nose, older patient, asymmetric tip, droopy tip, very droopy tip. And I made my measurements again. Here, I find the Pitangui ligament. I tie it, I cut it, because I'm going to use it in the end. These are the lower lateral cartilages. I measure the angle, if they are cephalically oriented or not. And then I make my measurement. This is the caliper I was telling you about. I make my measurements by using the caliper. I'm using my pen with the caliper. So here I'm sitting about 3 millimeters from lateral crura, and I measure 7 millimeters to leave in place, and the rest is going to be removed or turned in. When it's a strong cartilage, I don't turn it, I simply resect, like cephalic trimming. I always support with my index finger and dissect the cephalically trimmed part, as you can see here, by using sharp dissection and cut it out. So this is cephalic trimming. Then I'm going to make the new domes. The new domes first marked, and then by the help of two Brown SM forceps, I can show you the new dome. Then this new dome is sutured. What did I do? Look at the one that does not change. I rotated the tip. This is a wonderful way of rotating tip and also increasing projection if you want to. When you dissect the soft tissues in between, the tip drops down 2 to 4 millimeters. So you can compensate with these steel sutures very nicely. Again, this is hyodermal suture after transdermal suture, as we have seen. I'm going to pass this because you have seen this before. I'm putting a caudal septal extension graft. I put 2 spirografts in. I'm suturing a caudal septal extension graft because this is heavy skin and it's an old patient. I want more stability. That is why this time I'm putting a caudal septal extension graft. In half of the cases, I use these extension grafts because it's more stable. To stabilize it more, I put 2 spirografts. They don't need to be too long. They can be shorter spirografts, but they help me to fixate the caudal septal extension graft in the midline. Some of my friends are using it in an overlapping fashion. I don't like it much. Why? Because it's not easy to get symmetry the way you like it, and it can cause some problem at the entrance in terms of narrowing. So when we are done with suturing it to the spirografts first, then I suture it to the caudal septum. And after this, we simply suture the medial crura on this caudal septal extension graft. So this is her 16 months after surgery. As you see, not a perfect result, but a good result. And I have a heavy patient, and I'm a happy surgeon too. It doesn't drop as before. This is a young Turkish lady. So in beautiful girls, you have more beautiful results. Of course, this is what I want to show you. You can never get a super good result in a less beautiful face. And when the face is more beautiful, the result becomes more beautiful. So, profile is the second most important parameter in rhinoplasty. Precision profile plasty is an important target. Many surgeons rely on their aesthetic eye. We must work on creating the desired and best possible profile before going into surgery. If you want to learn more from me, in August I have my own course, and thank you very much for your attention. If there are any questions, I can answer you. One more time, thanks to Dr. Mahchoubi and his friends for the kind invitation. It's a great honor to be with Dr. Mehdi Najri in this meeting as well, and hope to see you in our next future meetings. Thank you. Bye-bye.
Merci beaucoup.
Je vous en prie.
Je pense que nous arrivons à la fin du congrès. On remercie tous les gens qui ont bien voulu patienter et nous attendre. Et je déclare la clôture de ce congrès en espérant vous revoir très bientôt à Sétif pour un nouveau congrès de lanol. Merci, au revoir.